Okay, I'm going to go ahead and try to finish this up. We stopped at otosclerosis, so that's where we're going to start. So otosclerosis, which should be page 690, I think, in TIMBY, is a fixation of the stapes. If you remember, the stapes are those stirrup like apparatus or mechanism in the inner ear. The fixation of the stapes is the most common cause of conductive hearing loss. Signs and symptoms develop in the 20s and 30s, so this can occur early. All right, causes are slow formation of the spongy bone at the oval window, causes the footplate of the stapes to become locked or fixed in a position, preventing conduction of vibrations from the tympanic membrane to the cochlea. So right in here, like a bony prominence knits itself into the stapes, and see over here how much thinner it is so that this can vibrate. Now when we have this extra spongy bone formation on there, the stapes can no longer vibrate and transmit the sound. All right, it is believed to be genetically acquired. It accelerates during pregnancy. Complications can be unilateral to bilateral conductive hearing loss. Assessment findings with otosclerosis, slow progressive hearing loss in both ears, although it can be unilateral. Symptoms are usually first noted when a person cannot hear during conversations, okay? Tinnitus, I know you guys know that one by now because I think I said it 100 times on Monday. But tinnitus, the perception of sound or noise in the ears without any stimulus from the environment. It's usually a buzzing, ringing, or roaring sound. Some people experience vertigo when bending over. They get real dizzy. Some diagnostic tests would be the Rhine to demonstrate that bone conducted tone is heard longer than air conducted tone, which is the reverse of what is normal. If you remember when we discussed it, we discussed that air conduction is longer than bone conduction. But if you have otosclerosis, you would discover the Rhine test would be the opposite, the reverse of normal. They'll do audiometric testing, and they would have mild to total hearing loss. And a CT scan would show the extent of the bone growth there on the stapes. Right, treatment for otosclerosis. So treatment, a hearing aid may improve hearing. Okay, obviously we're going to start with the least invasive and go to the most invasive. So we'd probably start with the hearing aid and see if that helps, if that makes a difference. We can also do what's called a stapendectomy, which is an incision made behind the ear, the post-auricular area behind the ear. They remove the stapes and insert a prosthetic stapes device in there. Post-op treatment includes hospitalization for 2 to 3 days, antibiotics. Position the client on the non-operative side. So if I had it done in my right ear, I would need to be positioned on my left side. Activity is restricted for 24 hours or more. There is a concern for dislodging the prosthetic. Facial nerve function is going to be assessed because we are going in behind the ear where the cranial nerve runs, and so there is a high risk of injury. So if we're going to do a facial nerve function assessment, hopefully you remember back from first semester what we would do with that. So you smile, frown, grimace. That's what you're going to ask your patient to do to see if they make sure there's no damage to that facial nerve. The nurse provides these post-op instructions to be followed until released by the primary care provider. Dizziness is common, so just let them know that dizziness is common. Ask for help with ambulation. They need to be sure that when they sneeze or cough, they do it with their mouth open because closed mouth causes increased pressure and can cause dislodgement of the stapes. If there's ear packing, swelling, or fluid in the ear can interfere with hearing temporarily, obviously. Excessive ear pain or drainage should be reported, though. They should not have excessive pain or drainage from this surgery. Avoiding loud noises, sudden pressure changes such as diving or flying. Don't blow their nose. Again, that's back up with sneezing and coughing because it increases the pressure in the ear. Protect the ears from cold or getting wet. Avoid activities that cause the valsalva. Again, that goes along with the sneezing, coughing, blowing the nose. Avoid people with upper respiratory infections because upper respiratory infection is going to cause you to start coughing, sneezing, and having to blow your nose more, which increases the pressure in the inner ear, which can cause dislodgement of the stapes. Changing the external ear dressing and incision dressing as instructed, washing the hands well before and after, but do not remove any packing that's placed. All right, they need to complete their antibiotics and see the doctor scheduled. All right, so that's it in a nutshell for otosclerosis. All right, now let's go to Meniere's disease. It's my little cartoon. I think I've been reincarnated as a merry-go-round. They're very dizzy all the time. This is on 693, I think, through 696 in your book. They have episodic symptoms created by fluctuations in the production or reabsorption of fluid in the inner ear. It is believed to be caused by malabsorption of fluid in the endolymphatic sac. So essentially, it's an excess fluid problem. Signs and symptoms, though, there is a triad. It is a triad for Meniere's disease. You have hearing loss, vertigo, and tinnitus. This triad, these three symptoms, hearing loss, vertigo, and tinnitus, pretty much come together. So the theories of etiology, there is an unknown etiology to Meniere's disease, but some of the theories are a congenital narrowing of the endolymphatic duct, allergic reactions, autoimmune responses, head injuries, or viral infections of the inner ear. Assessment will be severe whirling dizziness or vertigo accompanied with nausea and vomiting, tinnitus, and hearing loss. Unilateral, it's unilateral hearing loss. So again, those three things are that triad for Meniere's disease. They may also have progressive nystagmus related to an imbalance in the vestibular nerve. So they would have this jumping of the eyes. The attacks can last minutes to weeks, but most resolve sooner rather than later. All right. The onset is often very abrupt, very disrupting. This is basically a debilitating disease. People are very fearful to leave the home. They're often unable to work because they have no idea when an attack is going to hit that they get so dizzy. Basically, you have to rule out other causes for Meniere's disease. All right, we can do diagnostic testing, that caloric stimulation test, which uses temperature differences to diagnose the damage. When the cold water enters the ear, it causes rapid side-to-side eye movement. The eyes should move away from the cold water. Then warm water is placed in the ear. The eyes should move toward the warm water. And abnormal results would indicate that there is neural damage. So they can experience extreme vertigo with nausea and vomiting from the cold water as well. So this is one of the videos I have posted. I think it says Ashley's nystagmus, cold water nystagmus or something. And it is a little bit hard to even see his eyes jump in the person that recorded it. It's a little bit difficult to see, but it's if you pay close attention, you have to watch it a few times to be able to see what they're talking about. We can also do electronystagmography, a CT or an MRI to rule out tumors, audiometry to measure the hearing loss, electrocochleography, which confirms the diagnosis. They record the electrical activity of their inner ear in response to sound. Treatment and nursing care. We need to prohibit smoking because smoking causes vasoconstriction. Vasoconstriction interferes with the fluid drainage from the inner ear. Okay, it's like this vicious cycle. You just wouldn't put smoking together. What does smoking have to do with Meniere's? But if you think about it medically, this is what happens. You smoke, you vasoconstrict, you don't allow drainage of that fluid. All right, they're going to have bed rest, limited movement, provide safety during an attack, get up slowly, turning their entire body. Teach them to avoid allergens and take antihistamines if prescribed. When the primary care provider recommends hearing aids, refer to an audiologist for instructions and use of care. All right, medications for Meniere's disease would be things like meclizine. Trying to remember which name I need to tell you all. Meclizine, diazepam, promethazine, and hydrochlorothiazide. I think these are on page 696 in your book. Meclizine is an antihistamine that suppresses the vestibular system. Diazepam for acute episodes. Now, why do you not take diazepam long term? That's Valium. Right, you don't take it long term because it is very addictive. However, it will help control the vertigo. Promethazine, which is Phenergan, is an antiemetic for the nausea and vomiting related to the dizziness. Hydrochlorothiazide is a diuretic to decrease the fluid and help alleviate some symptoms. All right, we could also do surgery. Box 43.3 tells about this. Examples are an endolymphatic sac decompression, middle or inner ear perfusion, and labyrinthectomy, and vestibular nerve section. So the endolymphatic sac decompression is a shunting of the endolymph. It is actually the first choice, the most safe choice, is doing this endolymphatic sac decompression. Then we're going to go to middle and inner ear perfusion. So ototoxic antibiotic infusion into the middle and inner ear. There is a high risk of hearing loss with this. So this is why we obviously not going to be our first choice. Then we may do a labyrinthectomy, which is basically like is a vestibular nerve section. There has a very high success rate to it, but you usually already have a significant hearing loss before you attempt this, before you're going this far. Complications do include facial nerve damage and permanent hearing loss. So again, facial nerve damage, what do we want to ask our patient to do? Hopefully you remember that we need to ask them to smile, frown, grimace, all right, to assess and make sure there was no facial nerve damage. Right. We need to provide extensive psychosocial support during attacks, administer medications, limit movement, promote safety, assist with ADLs, acknowledge dealing with a temporary or permanent hearing loss is a challenge. We need to educate on a low sodium or salt-free diet. So what foods are we going to restrict on this diet? So hopefully you're going to pause and name down a few foods, and I'm going to tell you what I have listed. But first of all, why do we need to restrict the salt to the diet? So hopefully you know we're reducing the amount of sodium, leading to a reduced amount of fluid. So different foods, table salts, limiting or decreasing table salts, sauces, dips, processed foods, cured meats, bacon, deli meat, cheese, snacks. Those types of things are going to have a lot of sodium in them. We need to encourage drinking sufficient fluids, limiting coffee, tea, soda, and caffeine because they are diuretics. They have a diuretic effect on the body. Encourage eating fresh fruits and veggies and whole grains, limiting your alcohol intake, and avoiding aspirin as it increases your vertigo and tinnitus. We already talked about how aspirin was one of the 5 ototoxic medications I told you, ototoxic drugs I told you to know. Okay, so that finishes that up. Not very long. Let me see if I have any other pictures for you. Nope. Good luck on the test. So this test, I think I have 8 questions, and it'll cover all of ears. Otitis media. Wait, I gotta start backwards. Sorry. Hearing impairment, conductive hearing loss, sensory neural hearing loss, nursing interventions and approaches to those with hearing loss, otitis media, otosclerosis, and Meniere's disease. So there's only 3 ear issues, I guess, that I've talked about. So again, I think the best thing is to kind of put them in a chart and compare and contrast and figure it out the best that way. So again, I think I have 8 questions on the exam. So I don't know if I'll have 1 or 2, hopefully at least 2. Select all that applies. All right, good luck.